Thank you very much for inviting me to speak, and I think probably I'm going to have a slightly different take on your day. I think the first thing I would say is if you see somebody with syncope, I think it's fair to say the likelihood of them having a vestibular disorder is minimal. The only disorder I would ever countenance that might present in that way is vestibular migraine, or of course conceivably if they have a cerebrovascular event in the posterior circulation. Sorry, let me just get myself organised here. Right. So the first thing I think we have to think about if we're talking about dizziness is what are we actually talking about? There are a number of symptoms, and patients can choose any of these names when they come to tell you what's wrong with them. So vertigo, from our perspective, would be considered to be an illusion of movement, either of the patient themselves or of their environment. Dizziness is just a vague, I feel a bit giddy, I'm lightheaded, that sort of sensation. Pre-syncope is a sense of things going away from them and fainting, not arriving at actual loss of consciousness. And unsteadiness is something that they complain about in terms of they don't feel their legs are right, they can't move their legs properly and they feel unsteady. But any of those symptoms can present as dizziness, and in the past it tended to be thought that whatever the patient told you is the avenue you should pursue in terms of diagnosis. So if they said that they had vertigo, you should think about vestibular pathologies. If they said that they had pre-syncope, you should be thinking about cardiovascular, and that probably to a great extent is still true. If they said they were unsteady, you would think more of neurological disorders, etc., as listed up here. But there's lots of evidence in the literature now that shows that that is not correct. And one study that perhaps is particularly pertinent to today's discussions is this study by Newman Toker. He looked at almost 1,700 patients with cardiovascular disease of 3 particular types and identified that 63% of those had vertigo, as defined in the previous slide, and 37% had dizziness. So clearly they didn't all present with syncope and pre-syncope, and so one certainly should be thinking much more broadly when one's thinking about balance disorders and dizziness. And if we look at how common these are, and I'm now going to go on to an evangelistic mood about dizziness, because exactly as Roseanne was saying about falls and syncope, I feel this about dizziness. It's the most overlooked symptom ever. If you are dizzy, you are really impacted upon in terms of your everyday life, and it's terribly common. If we look generally at the US and UK studies, and I've just quoted 2 here, the lifetime prevalence is between 20 and 30%, and if we look at a big meta-analysis that was recently done by Louisa Murden in my department and Anne Schilder at UCL, they looked at the lifetime prevalence of vestibular vertigo and saw that it was 3 to 10%. Dizziness was even more common and was much more associated with, they said, with general medical disorders. And I think that probably is correct, but certainly is not the only explanation. So let's just briefly revise what we know about balance. You have 3 sensory inputs: vision, proprioception and somatosensation, and vestibular inputs pass into the central nervous system. They're integrated in the vestibular nuclei and modulated by other centers in the central nervous system to provide a perception of stability, which is what the patient comes to complain about usually. They control the vestibulo-ocular reflex, and eye movements are really the easiest way for us to document and classify vestibular disorders, and posture and gait. There are various other outputs from this integrated and modulated activity, but I'm not going to talk about them today. So given that that's clearly a very complicated system, as you've already heard, you can divide symptoms of dizziness into really 3 major categories. They either are associated with general medical disorders, and I don't intend to talk about those because obviously we're all trained in medicine. They can be neurological disorders, and I do tend to just briefly touch on the ones that I think are life-threatening, because there are a few of those. And mainly they arise because of labyrinthine or labyrinthine connection disorders. There are a few odd things like ocular dizziness associated with wearing varifocal lenses for the first time. People feel very disorientated. Cervical vertigo is a very controversial issue, and I'm honestly not going to talk about it. I personally don't believe it exists, but many people do. And multisensory dizziness, which is common, much more common in the elderly, and is comprised of at least 2 of the 3 systems I've mentioned as being important for balance, being mildly impaired, and maybe all 3 of them are. So the elderly patient who's had a peripheral vestibular disorder, labyrinthitis, for example, in the past, compensated well, but now has developed macular degeneration, so hasn't got good vision, and maybe has rheumatoid arthritis or osteoarthritis, and therefore all the sensory inputs are marginally impaired, and the brain doesn't work quite so well either. So that's what multisensory dizziness is. I now want to just go through with you the various presentations that you can see in people that are presenting with acute episodes and chronic episodes for that matter too. I'm going to use the term vertigo, but in all honesty, please remember what I said at the beginning. That can include dizziness, unsteadiness, the works. The commonest presentation in all balance units by miles is vestibular neuritis. I've linked it with labyrinthitis because really the only difference is labyrinthitis has hearing impairment with it. It isn't just vestibular symptoms. But most commonly, vestibular neuritis is thought to be due to an inner ear viral infection, but obviously you can get vascular peripheral vestibular disorders, which can be very difficult to distinguish from viral ones. The presentation I'll go through in a second. I'm going to say a word about cerebellar infarction because in the accident and emergency unit, that's a major concern. Isolated single attack of vertigo. Are you looking at something that might go on to a stroke, or are you looking at very benign vestibular neuritis that will almost certainly get better? Vestibular migraine is really a relatively recently recognised entity. I would say in the last 10 to 15 years it's become much more apparent that this is a common problem. It's the second commonest presentation in all the studies now looking at vestibular clinics. Demyelination, I would just say 5% of people with multiple sclerosis will present with a single acute episode of vertigo. The thing to do, if you're at all concerned that they've had any previous neurological symptom, is to investigate them with evoked potentials and, of course, the gold standard of an MRI. Autoimmune inner ear disease is another condition that can present with a single episode the first time you see them, although it goes on to recurrent attacks, and I'll talk about it in a minute. So vestibular neuritis can occur at any age. It predominantly affects young and middle-aged people. It usually is spontaneous. People don't recall an infection, but in the literature, certainly there are reports where people have had upper respiratory tract infections or gastrointestinal infections. The acute spinning symptoms will last for 3, 4, 5 hours, and patients will then feel unsteady thereafter, and that can resolve in a day or two. It can take weeks and even months to resolve, depending on compensation, which I'll just discuss later. Certainly, autonomic symptoms are common in the acute stage: nausea, vomiting, and diarrhea, and sweating. There usually are no systemic symptoms unless they've got a coincidental virus, when they may have a headache and a fever. Diagnostic pointers to this condition are the hearing will be normal unless they've got labyrinthitis, and then they will be complaining of a sudden unilateral sensory neural hearing loss at the same time. They will have spontaneous nystagmus, which will always be unilateral and horizontal. And what I mean by unilateral is wherever their eyes are directed, right, left, up, down, in the centre, the nystagmus will beat in the same direction. And they'll have a positive Halmagyi head thrust. And I'm just going to go through this because I think for any physician, it's worth knowing how to do this. I have to say it can be difficult to interpret when you start, but keep doing it because you will get the hang of it. So what is the Halmagyi head thrust? Well, what we're looking at is abnormalities of the vestibulo-ocular reflex. If I look at straight ahead and I turn my head to the right, but I want my eyes to be straight ahead, my vestibulo-ocular reflex actually makes an exactly equal but opposite movement in the other direction. So I turn my head to the right, my eyes go to the left. And that's what we're seeing up here. Patient is looking at your nose as you're examining them. You're turning their head to the right. Their eyes go exactly opposite and equal degrees to the left so that they keep their vision fixed on you. If you've got an abnormality of your vestibulo-ocular reflex, you can't do that. So this is, again, patient looking straight at you. You ask them to fixate on your nose. You turn their head to the right, and you can see this time his eyes haven't gone to the left. They've gone off to the right. He then quickly makes a catch-up saccade, a fast eye movement, to get his eyes back in the right position. And I will show you a video to try and make this clearer. So this is a chap who has a left vestibular ocular reflex abnormality. It's hard to see actually in this more distant view, but we'll zoom in on his eyes in a minute and then I'll show you. Just look, when we turn his head to the left, he makes a catch-up saccade. But when you turn his head to the right, he stays right on target. So to the right, he's perfect on target. To the left, he makes a quick eye movement. So that is a positive Halmagyi head thrust test, telling you that this chap has got a left inner ear abnormality. If you've got a neurological abnormality or some other cause of dizziness, this will be normal. So the importance of this is really in this condition, which is coming up next, if I can bring it up. Sorry, can somebody move the slide on to the next slide, please? It's not moving with me. There we go. Pseudoneuritis, which in fact is really a cerebellar infarct. What we're looking at here is the cases that are so commonly missed in the accident and emergency department where people come in with acute vertigo, and because they're maybe 45, they're not very old, they haven't got lots of evidence of vascular disease, everybody assumes they've got vestibular neuritis, but they haven't. They're having a stroke, and you don't need to miss these people because about 35% of them are missed in casualty, and of that 35%, 40% will have very significant morbidity or die. So you really do want to pick them up. So how do we differentiate them? Well, it is difficult, let me say, but to date, if you review all the literature, the best pointers I've listed here, firstly, they have got profound imbalance. People with vestibular neuritis are all over the place. They find it difficult to walk, but they can manage. They don't go down in a heap. 70% of these people cannot stand up if you don't hold them. They're absolutely incapacitated. They will have direction-changing nystagmus, so they will either have nystagmus beating to the right when they look to the right and beating to the left when they look to the left, or they may have vertical nystagmus, but they will not have the unidirectional horizontal nystagmus that you see in acute vestibular neuritis. They may have a skew deviation, and what I mean by that is their eyes, one eye will be higher than the other, they won't be absolutely parallel. You often can't see that if it's very slight, if you just look at them directly, but if you do a cover test and just do this, you'll see their eyes doing this, so you'll pick up the skew deviation. And the Halmagyi head thrust will be normal because they do not have vestibular loss. Of course, the gold standard is to get a diffusion-weighted image with MRI. But those are the best ways of trying to pick this disorder up. And I think if one follows that approach, one will do much better than any other approach. So what about recurrent episodes rather than single episodes? Well, one of the most common presentations is a decompensating peripheral vestibular disorder. They've had an acute vestibular neuritis, they've got better, and you're seeing them 9 months, 3 years, whatever down the line, and they're having more dizziness, and I'll talk about that in a second. Meniere's disease, I'm actually not going to talk about it. It's not that common. I mean, of course, if you work in a balance unit, you see a lot of it, but in the general population, you don't see a lot of it. The triad of Meniere's disease is fluctuating hearing loss, tinnitus, and acute episodes of vertigo. It all comes on like this. The patient drops to the floor. Often they've had, I can't think of the word, before it starts, they've had a sensation that their ear is filling up and their tinnitus will have increased and they'll feel their hearing is muffled. And then they collapse on the floor, vomiting. And often that episode will go on for 4 or 5 hours. Can be shorter, but it's usually that sort of time. And then it'll all settle. Their hearing in the early stages will come back, may not come back to normal, but it may do, but it'll improve. The tinnitus will subside, the pressure will go, and the dizziness settles. And in between these acute episodes, in the early phases of the disease, they'll be well. So that's how you diagnose Meniere's disease. Really, it is a clinical diagnosis. I would say if there's ever any doubt, I'm not going into the details of neurological investigations because I'm sure most of you aren't going to do that. But if there's any doubt, that's what should happen. They should have full auditory and vestibular investigation. Secondary hydrops is exactly like Meniere's disease, except it occurs in people usually who've got a congenital profound hearing loss. So in children that are born with hearing impairment, when they get to teenage years or late or early adolescence, they will begin to have episodes of dizziness. Not all of them, of course, but a significant number, and that's just called secondary hydrops. Vestibular migraine I'm going to talk about in a minute. Autoimmune inner ear disease. This is the disorder I said earlier. It's a particularly unpleasant and difficult disorder to treat. The patients with it have acute episodes of dizziness and acute episodes of hearing loss, which may improve or may not improve, and they're incongruous in that, for example, they'll have acute vestibular symptoms in one ear. They can't tell you that, but your tests will tell you that when you investigate them. Then they'll have hearing loss in the other ear. That'll get better. Then they'll have vestibular symptoms in this ear, another episode of vestibular symptoms a couple of months later, and then they'll have hearing loss in the other ear, and so it goes on with a gradual reduction in both ears of hearing function and vestibular function. It may be present as part of an overall systemic autoimmune disorder, or it can occur independently as an isolated disorder, and that's particularly difficult because none of the inflammatory markers are necessarily up. In the States, they diagnose it by treating with steroids, which is really not acceptable because most vestibular disorders will improve on treatment with steroids, so it's certainly not a diagnostic test. So that can be a very difficult disorder both to diagnose and to treat. I want to just say a word or two about acute vestibular symptomatology and compensation so that you can understand what I was saying about recurrent decompensation. From day one, when you start moving around, you have inputs every time you make a movement from the three systems we've discussed. At the same time, your brain develops a central store of what those various inputs are for a particular movement. And when in adult life you make the same movement, you have expected afferents and you have input afferents. And if they match in this lock and key system, you're fine. You make the right vestibulo-ocular reflex, you move around normally and you feel perfectly stable. But if for some reason one of these inputs fails or is not so good, you get this system where one of them is out of kilter and you feel dizzy and disorientated. You get better because the brain, by means of substitutions and adaptation and recalibration of the vestibular reflexes, alters this central store and you get back to normal. So if you think about it, this is exactly what happens to the sailors who go out in boats that tip everywhere and they're all motion sick. 3 days later, they're better. The reason they're better is because their brain adapts this system such that the inputs they're now getting, they recognize as being normal and they're fine. But this is also the way you get better from vestibular disorders. So if we then consider somebody who's had the vestibular neuritis in the past, so this is balance on this axis, normal up here and terribly impaired down here. This is recovery in terms of time. So they're perfectly normal. They have their vestibular neuritis. They get better over a very variable, and it says really arbitrarily here 6 weeks to 6 months, but it can be a week and it can be 2 years. They do gradually get better, most of them, not all of them. And then they're well for a while, but if they get any physical illness or psychological disturbance, they can have more episodes. And this can be a repeating pattern, but you can see that the episodes get less severe. So when you take the history, you need to ask people, was the first episode you ever had much worse than subsequent episodes? Because that's a good pointer to the fact that you'll be dealing with this type of disorder. And then you have to sort out why are they decompensating. Have they got some other medical problem or have they got some psychological problem? Psychological problems being a major problem with vestibular disorders. 40% of patients will go on to get anxiety or depression if their vestibular symptoms don't improve. Turning to vestibular migraine, as I said, this is the second commonest cause of acute vertigo and dizziness, and it remains hugely unrecognised because 50% of presentations do not have headache, and most people think of migraine as a headache disorder, whereas of course migraine is a disorder that just has headache as the primary presentation. And the presentation can vary between subjects and within subjects, so you can see somebody one time having a headache, 6 months later they'll have a vestibular disorder, 3 months later they'll have headache and a visual disorder, and there's all sorts of combinations, and you have to explain to the patient, because most of them find it very difficult to understand their dizziness is related to their headache, that actually this is normal. To make the diagnosis, I won't read all these out, you can look them up. The Bharani Society is the International Society for Vestibular Disorders, and this is a working party that came up with these criteria for making the diagnosis of vestibular migraine, which is now into all the standard diagnostic category criteria. What are the pointers to make you think about this diagnosis? Well, a past history of obviously migrainous headaches and a strong family history is very common. People that are motion sick in the back of the car looking at a map, etc., that's very common in migraine. Exercise, stress, pressurized lifestyle, which applies to most of us probably, and dietary induced such as chocolate, cheese, red wine, citrus fruit and caffeine are all things that commonly trigger migrainous attacks. Often you can get evidence for migrainous aura and hypersensitivity symptoms, even with the spinning dizziness. You wouldn't expect them to be photophobic, but they often are. Childhood presentations that are listed here are very common, and you must ask about them if you're suspecting this diagnosis. There's normal hearing in migraine, and if you look at them from the vestibular perspective, although their symptoms are dreadful, they can be really incapacitated with spinning dizziness, they actually don't have any abnormalities because the problem is the information is not being integrated properly. It's not that there's any damage being done. So posturography, for instance, a test where you stand people on a platform and see how they move around and balance, that may be abnormal, but of course that doesn't actually give you a diagnosis. It just tells you that they have got a balance problem, even if their vestibular system seems intact. Coming on to very brief episodes of vertigo, things that just last a few seconds, by far and away the most common disorder is benign paroxysmal positional vertigo, listed at the top here. Yes, you have to think about TIAs in the posterior circulation, and I'll say a word about that in a minute. Vestibular paroxysmia is a condition that's very similar to trigeminal neuralgia in as much as you get bursts of dizziness, spontaneous, you can't identify any triggers, they're very incapacitating, and 9 times out of 10, all your tests will be normal. You treat it with carbamazepine. It used to be said that it was the result of an aberrant blood vessel pressing on the 8th nerve, but that's really not correct, and certainly at Queen Square, where I've worked all my life, the neurologists are always saying this is irrelevant. Superior semicircular canal dehiscence is acute vertigo that's precipitated by noise because there's erosion of one of the labyrinth semicircular canals, the osseous erosion, so that the membranous labyrinth is left free, i.e. there are 3 windows. There's the round window, the oval window, which are normal, and then there's this third window, and this third window allows stimulation of the vestibular apparatus with pressure changes due to noise in the inner ear. It's rare, but when you've seen it, it's very interesting. Idiopathic, sorry, the C's got left off that, idiopathic and ototoxic vestibular failure. I highlight this because over the years I've seen innumerable cases of ototoxicity due to gentamicin in subacute bacterial endocarditis, as well as in septicemia, and peritoneal dialysis is another common one. And often the physicians looking after, or the surgeons looking after the patient, have not appreciated that actually the dizziness isn't because the patient's been lying in bed very sick for weeks, or often they think they've had a brainstem stroke when there's no evidence of that, and actually what you're looking at is the onset when patients get up and are dizzy of vestibular failure as a side effect of the streptomycin and aminoglycoside antibiotics. So do think about that. In idiopathic, this is almost certainly a genetic abnormality, although it hasn't yet been, the genetics haven't been defined, where patients have very brief spells of dizziness, and if you investigate them, you can see their vestibular function is gradually going down, and they end up with perfect hearing, but loss of vestibular function. Benign paroxysmal positional vertigo, I suspect you all know what this is. It's brief spells of dizziness. It's commoner in the older population, but it can occur spontaneously in anybody. It's very common after trauma, even trivial trauma of banging your head on a kitchen cupboard. Previous otological problems also give rise to this disorder. It's almost always associated with head movement, i.e. extension of the neck or flexion of the neck and tipping your head depending on which ear. It's tipping it towards the side affected. So, for example, looking up at a cupboard to get something out, so often it's called top drawer vertigo. The dizziness is very, very brief, usually just seconds. People may feel a bit sick with it, but there's no other associated symptoms. Hearing's normal, and the only way you can really diagnose this is the classical nystagmus, positional nystagmus on the Hallpike manoeuvre. So just to recap, the vast majority of positional nystagmus is BPPV. It's due to crystals falling off the otolith organs, which is the saccule and the utricle in the labyrinth, and irritating most commonly the posterior semicircular canal crista. This is the crista of the rotational organs here. And that gives rise to stimulus of the vestibular system and the spinning the patient gets. When they put their head upright, the crystals tend to drop down where they don't interfere with the crista, and the dizziness stops. I'll show you the Hallpike manoeuvre in a minute, but the importance is every elderly patient who's dizzy should have this Hallpike manoeuvre test, because this is something that is dead easy to cure and is very related to falls. And Joanna Lawson, who's worked with Roseanne for many years, she found that in the elderly population, needless to say, they don't always give you a clear history. They don't always say they've got positional dizziness. And it's such a pity not to treat this because it makes a huge difference to their overall balance. And as you can see, a particle repositioning procedure, whatever type you choose to do, most of the literature represents about 85% of people getting better the first time you do it, and a significant number the second time, as long as you know what you're doing. So it's worth learning that as well. The Hallpike manoeuvre is this. You sit the patient on the end of the bed in the upright position, turn their head 45 degrees towards you, and whip their head back over the edge of the bed. What you're looking at is their eyes, obviously, and you're looking for rotational vertigo. Nystagmus, sorry, rotational nystagmus like this. So the two eyes will go like this towards the undermost ear. If it's peripheral, which 98% of it will be, then there's a latent period before that nystagmus starts. The nystagmus is rotational. People intensely dislike it. It's a very unpleasant sensation. They feel very dizzy, but it stops usually in less than 60 seconds. It's usually, I would say, 15 to 30. And if you repeat the procedure, you won't get it. There's fatigability and you don't see it. Central positional nystagmus, which is incredibly rare and a very serious disorder that must have neurological referral instantly, has none of these features and commonly presents with vertical nystagmus. So finally, to just say a word about episodic vertigo and vertebrobasilar strokes. This is a very nice study that was done in Oxford some years ago now, looking at about 1,200 patients, as I remember, that had had strokes retrospectively, and of whom 257 approximately had brainstem strokes. And they were looking at the temporal relationship of transient isolated brainstem symptoms prior to the stroke. And what they found was that most of these symptoms, which included things like dysarthria, hemisensory symptoms, diplopia, fifth nerve symptoms, most of them didn't meet the National Institute for Neurological Diseases and Stroke definition for TIAs, but the patient reported them. So they considered them in this study, and what they found was that these transient episodes were far more common in the 2 days before a vertebrobasilar stroke than a carotid stroke. So if somebody complains of these when they come in with their vertigo and says, I've had lots of them, they're spontaneous, they're not related to movement or anything else, they really do need a proper neurological examination very quickly. The only significant characteristic that they found in all of their cases was there was a vascular risk factor, not surprisingly. But these patients do need urgent investigation, and these are the things that you can do in the emergency department to try and sort out which of the patients should have this prompt neurological assessment. A negative head thrust that I showed you earlier on, profound gait instability again, which I mentioned in the cerebellar infarcts, any eye movement disorder, so if the eyes aren't absolutely aligned, if there's an internuclear ophthalmoplegia or any saccadic abnormality, then you should send them off instantly, and if they give any history of any earlier neurological abnormality. Chronic dizziness I'm not really going to talk about, but these are the things that you might consider. It's worth remembering that psychological disorders themselves can give rise to dizziness, anxiety, panic attacks, etc. But equally, the point I made earlier, 40% of people with chronic vestibular symptoms will develop anxiety, depression, avoidance behaviour and panic attacks. So they need to be properly investigated neurologically to sort out, have they got a psychological disorder or have they got a vestibular disorder. So in conclusion, I would say you really do need to take a good history in vestibular patients, as in all cases in medicine, and you need to do a full examination that looks at eye movements, looks at hearing, looks at neurology, cardiovascular system, and of course, general system. But the three things that you need to do that you might not otherwise do, you need to do a Harmagi head thrust test, you need to do a hornpipe maneuver, and you really need to look at eye movements. So I hope that's helpful in trying to sort out dizziness. Thank you.